We start by drugs which inhibit cell wall synthesis. We have beta-lactam antibiotics, which include penicillins, cephalosporins, carbapenems, and monobactam. Penicillins, they are derived from 6-aminopenicillinic acid, and they are obtained naturally from Penicillium mole of fungus or prepared semi-synthetically. Mechanism of action. They are bactericidal by inhibiting cell wall synthesis. So they affect a growing organism, not resting one. And they are inactive against tubercle bacilli, fungus infection, and viruses. They bind to penicillin binding protein, which is transpeptidase enzyme, so prevent cross-linkage between peptide chains which are attached to uronic acid. And also they enhance activity of autolysis. Of course, they have no effect on bacteria which have no cell wall as mycoplasma. And they have no effect on human cells because human cells do not contain cell wall. Classification. Short-acting penicillin, benzyl penicillin or penicillin G. It is acid sensitive, so it is given either intramuscular or intravenously. Duration is about 4 to 6 hours. Duration is short due to rapid renal excretion, mainly by tubules, about 90% by tubules, and 10% is filtered through glomeruli. Propenicillin inhibits renal tubular secretion, so increases penicillin level in blood. It is narrow-spectrum, it has no effect on gram-negative bacilli, and it is penicillinase sensitive or beta-lactamase sensitive. It cannot affect bacteria which form penicillinase or beta-lactamase enzyme as some strains of Staphylococci. To prolong its duration, it is combined with procaine or with benzethine. Procaine penicillin G duration is 12 to 24 hours. Benzethine penicillin G duration is 1 to 4 weeks. Both are acid sensitive, they are given intramuscular, and they are penicillinase sensitive, and of course they are narrow spectrum. Sometimes the penicillin G is combined with procaine penicillin to produce fortified penicillin. And here there will be high blood level and longer duration than penicillin G. We have acid-resistant penicillin, phenoxymethylpenicillin or penicillin V. It is similar to penicillin G, but it is effective orally. It is not a spectrum penicillinase sensitive. Now, penicillinase resistant penicillin. We have methicillin. It is acid sensitive, so it is given intramuscular, but it is nephrotoxic, and some strains of Staphylococci become resistant to methicillin. They are called MRSA. MRSA is methicillin resistant Staph aureus. We have orally active preparations, including oxacillin, coloxacillin, dicloxacillin, flucloxacillin, and nafcillin. Nafcillin oral absorption is incomplete, so it is better given intramuscular. This is the only group of penicillins which are penicillinase or beta-lactamase resistant. Broad-spectrum penicillin, aminopenicillin. They include ampicillin and amoxicillin. They are effective orally. Ampicillin absorption oral is not complete and it is decreased by food, while amoxicillin is better absorbed orally. It has better oral bioavailability and its absorption is not affected by food. Although they are broad spectrum because they affect also gram-negative bacilli, but they are penicillinase or beta-lactamase sensitive. So they can be combined with penicillinase resistant penicillin For example, Ambiclox, which is ampicillin combined with colchicillin, or those penicillinase enzyme inhibitor as clavulanic acid or sulbactam. Ampicillin esters, they are called proampicillin. They are prodrugs. They are inactive and they are converted into ampicillin. For example, bevampicillin, palampicillin, and betampicillin. They are better absorbed orally than ampicillin, but they must be deesterified in gut mucosa and liver to release ampicillin. So they get higher blood level and they have less side effect on gut. The last group is anti-Pseudomonas penicillin or extended spectrum penicillin. They are highly active against E. coli, Proteus, Pseudomonas, Enterobacter, and Haemophilus influenza. They are penicillinase sensitive, so they are synergistic with aminoglycoside, but they should not be mixed in the same syringe. They include carboxypenicillin, which is carbapenicillin, which is given by injection, intramuscular or intravenously, and you have uridopenicillin, as ticarcillin and bepracillin, azlocillin. They are given by injection. They act also on Klebsiella and can be combined with beta-lactamase inhibitor. They are more active and more tolerated than carbapenicillin, and they are used also in anaerobic infection. Antibacterial spectrum. Penicillin affects gram-positive and the negative cocci, positive bacilli, spirochetes, and actinomyces. Extended spectrum and broad spectrum affect also gram-negative bacilli. Resistance to penicillin may be due to lack of peptidoglycan structure, for example in mycoplasma, or more commonly due to formation of penicillinase or beta-lactamase enzyme. Pharmacokinetics. After absorption, they are distributed to all tissues, low level in CSF except in meningitis because they can cross to brain if there is inflammation, excreted mainly by tubules and partly by glomeruli. Therapeutic uses: treatment of streptococcal, staphylococcal, pneumococcal, and gonococcal infection, syphilis, actinomycosis, diphtheria, meningitis. Also in typhoid fever, we give ampicillin or amoxicillin. In urinary tract infection by broad spectrum and extended spectrum penicillin. In prophylaxis of streptococcal infection in rheumatic fever by benzazine penicillin, 1.2 million units intramuscular every month until age of 20 years, and also in prophylaxis of subacute bacterial endocarditis. Toxicity of penicillin. Penicillins are among the safest antibiotics. Hypersensitivity reaction may occur, and the major cause is penicilloic acid, which reacts with protein and serves as a heptin to cause immune reaction. Allergy may be in the form of rash, itching, urticaria, angioedema, or the most serious anaphylactic shock. There is close allergy with other beta-lactam antibiotics. Diarrhea by destruction or affection of normal balance of intestinal microorganism or intestinal flora with incomplete absorbed penicillin, especially ampicillin, and superinfection may occur on long use, and superinfection may be bacterial or fungal. Moniliasis. Very high concentration intramuscular produce local pain and induration at site of injection, and intravenous preparations may produce thrombophlebitis. Acute interstitial nephritis with methicillin, carbapenicillin, and ticarcillin, and very large doses of penicillin G may affect platelet dysfunction and decrease platelet aggregation. If penicillin is given in very high doses or intrathecal, it may produce seizures and epilepsy.